Okay. Yay, it works. All right. So first of all, let's have our participants introduce themselves.
Hi, I'm Mindy.
Hi, I'm Stephanie.
I'm Lori.
I'm Christina.
I feel like somebody needs to. It's like we're getting a band back together. Okay. All right. So you're gonna go ahead and put on the belly. So the belly she's gonna put on. This is Mom and Natalie. So we'll have these in the rooms. It's like I said, this is the inexpensive low fidelity simulator that everybody should have. So just kind of straps on around the back, and then you put the gown on, and you look really pregnant. The funny thing is when people put it on, they can't sit up, and they're like, oh, and we're like, oh, it's real. So, all right. So here's we're going to show you guys kind of how this starts. So first thing I'm going to do is, so she's going to be our patient. We're going to give her a microphone so she can hear different people talking. So what we're going to do is we're going to start with the basic assumption. Oh, yay, another microphone. And that is everybody here is intelligent, well-trained, wants to do their best. We are here to improve patient outcomes, and we're going to practice. So thank you for volunteering. First thing we're going to do is we're going to assign roles. So I'm going to have, so who's the OB hospitalist we decided? You weren't here, so you got voted. All right, so let's see. So we're going to have our charge nurse. Let's see. All right, who gets to be charge nurse? And then I think I had one other one. Oh, I don't see primary nurse. I don't think we brought it in. We're just going to say ED nurse, but you're just the nurse. You're just the OB nurse. Okay. So we've assigned roles. Just so you all know, this is a little hint about simulation. If you're in a simulation and they're assigning roles, at least for an OB simulation, there are two things you always want to volunteer to be. Pediatrician. Because we have no idea what they do. They just stand there like, I'm here, and like, they hand them a baby and they go over here. Number two, anesthesia. Yeah, I've got the airway. Like and then that's it. That's all they do. So if you have the option, those are the two that you pick. Okay, so now we're going to start with this. So now we've assigned roles. So I'm going to. So do you have your instructions there?
I do, but I left my glasses at the table, so we're
gosh,
winging
that's hilarious.
Yep.
Okay, so she's gonna read. So basically on here we have family member patient instructions, and so she's gonna read those. And so when you're running at your institution, the way I generally do it is I will have one person who. Here's your glasses.
Oh,
Thank you, Brooke. Let's give Brooke a hand, everybody.
Thank you, Brooke.
When you're running this institution, what I like to do is I like to step outside the room with the people that are going to be participating, and then grab the first person who's going to come in and say, "I'm going to tell you the story," because what I want to hear is that relay of information between the first person and the next person that comes in. In here, it's kind of hard, so we're just going to do this. All right, who's going to be the primary nurse? All right, so I'm going to read you her information. So this patient, 27-year-old, G2 P1 001 at 37 and 4 weeks. Her first pregnancy was complicated by preeclampsia at 36 weeks. She has had an uncomplicated prenatal course and has no known drug allergies. She presents to triage for a complaint of a headache that did not go away with Tylenol. She describes the headache as frontal and rates it as a 7 out of 10 in severity. You do not have any labs right now. So she just arrived in triage. She was placed on the monitor. She does not have an IV. Her first blood pressure was 188/115. I heard that. It's so fun. I said, and everybody goes, ooh. Okay, and so basically what we're going to do is we're going to start. You're going to go in, you're going to meet the patient, you're going to start your assessment. I will be showing you vital signs and then directing you. If you need anything in terms of medications, an IV kit, anything else here, please, after you've assessed her, call for assistance, help the way that you normally would. Okay, any questions? All right, so we're going to start. I will play vital signs and scene.
Hi, my name is Stephanie. I'm going to be your nurse today. Tell me what brought you in.
I have a really bad headache.
Okay, where do you feel your headache at?
Right here.
And what do you rate that at a scale of 1 to 10?
Probably a 7.
7, okay. Are you having any other complaints, any other symptoms? Any nausea, any vomiting today?
No, nothing I can think of.
Any pain in your stomach on either side?
don't think so.
Have you been feeling any contractions?
I'm not sure. I don't think so.
Okay. 188. Okay. Her blood pressure is 188 over 115. Oh no. Bing bong, bing bong. Okay, so you had a history of preeclampsia with your first pregnancy?
Yes, but I don't want to be induced with this one.
Well, we'll see. We'll see about that. Okay, so that is your second severe pressure. So we are going to start an IV, and I'm going to call my charge nurse in to come help me with some things.
Charge nurse.
Starting your IV. What's going on? Okay, so this is Miss Foster. She is a G2P1, and she came in with a complaint of a headache here. She's rating it 7 out of 10. She has a history of preeclampsia, and she's had 2 severe blood pressures. Her last was 188 over 10. So, yeah.
Okay, I see you got the IV going. Have we treated her with anything?
180 over 110.
Okay, so let's go ahead and give our standing order dose of hydralazine.
Okay.
And then have you called a code OB hypertension?
No, I'd like to do that.
Okay,
Let's do that.
let's code OB hypertension LDR2. And that gets our OB hospitalist.
Giving 5 of hydralazine per the standing order. Okay. Hi, doctor. OB hospitalist. This is Miss Foster. She came into our triage unit with complaints of a headache. She rates it 7 out of 10 and is not going away with Tylenol. She has a history of preeclampsia with her first pregnancy. This is her second pregnancy, and she is 37 weeks. She's now had 3 severe blood pressures, 180s over 110s, and I've just treated her with the 5 of hydralazine for our standing order.
Okay, it's been 15 minutes.
Okay. So we'll
So
see.
what else would we like to do? So do you like labs?
Bing.
Yes, we
Bing.
need to get a PIH panel, and we'll see what this blood pressure is. Oh, sorry.
Here's your blood pressure.
175 over 110.
Okay, so it's still severe, so let's give her 20 of labetalol IV.
20 of labetalol.
Okay. It's been another 10 minutes.
175 over 110.
Okay, so that labetalol didn't work, so we're going to give you another dose of 20 of labetalol. Same dose you got the first time.
How's your headache?
My head still hurts, and I still don't want to be induced.
And you probably don't want an epidural either, do you?
So what is the plan?
We're going to see what this is, and we're also going to get a magnesium drip started on you just to prevent you from having a seizure or potentially a stroke.
Magnesium, would you like a 4-gram loading dose?
Oh, 4-gram loading dose, 2-gram maintenance. So you'll be on this for at least 24 hours after you deliver. It'll be continuous.
We are, next set of vital signs.
Okay, so we're going to actually double that dose of labetalol and do 40 milligrams IV. Oh, I thought we did 20 twice. Yep, so we're going to increase that to 40. We're going to get that,
Labetalol given.
and that mag bolus is going.
Still going. Yep.
All right, it's
So-
been 10 minutes, and here's your new blood pressure.
Okay,
145 over 95.
awesome. Yay.
But you're still having your babies.
Again? So what's the plan now?
So we're going to stay on this magnesium drip. You're going to have to stay in the bed. Won't be able to move around too much, but we'll move you around while you're laboring. And we're going to have to induce your labor. I'm sorry, I know that wasn't your plan, but just to keep you and your baby safe, we'll try to work together as much as possible.
Okay.
All right, and scene. All right, everybody. All right, good job, everybody. Okay, so now we're gonna take a moment. We're gonna go over the debriefing. Okay, so again, I'll let you guys just like grab a seat. You can take those things off. Oh, you don't want to wear the belly? You're good? Okay, I know. You're hot? It's like the first time today. All right, so you want to sit on the bed? Okay, so first thing, I always start off with the basic assumption. Everybody here is intelligent, well-trained, wants to do their best. We are here to improve patient care. So, so for this scenario, so first of all, what was the scenario? Like, what was this one about?
Hypertension.
Yep, hypertension, absolutely. Do you guys ever, like, how often do you see this?
All the time, every day.
All the time? Like every day?
Yeah,
Okay, so this is something you guys are pretty familiar with.
yes.
Yeah. Do you feel like you're seeing it more?
A lot more, yes.
Okay. All right, so I'm going to stop because what I'm going to do is, as we're doing the debriefing, I'm going to jump in and out of character. So what I'm doing there, one of the ways to get people involved in talking about stuff is to ask them if they've seen it before. Okay, so another thing I'll do is like, has anybody, like, if it's an eclamptic seizure, like, who's seen an eclamptic seizure? I'm like, great, tell me about it. Tell me about the last one you saw. If you do that, it already gets them in the mindset, and then they start talking. And then you avoid that. So, how did we do? And it's silence. Okay, so if you ask about previous experiences, it will get people kind of talking. Okay, so we're going to run through the checklist real quick, and then there's a few points that we'll focus on. So number one, so from the hospital standpoint, do we have standard early warning signs, monitoring, diagnostic criteria for preeclampsia at your institution?
Yes.
Okay, all right. And then when you're putting those in place, is it electronic? Is it, you know, like how does that work?
So we have a standing order set for all of our order sets. So for our OB triage in this example, we have a standing order of 5 of hydralazine after their second confirmed severe blood pressure. And with that order, we give the hydralazine and then we notify that physician for further orders. And then at that point, if she's continuing to have those severe pressures, we would start our hospital systems algorithm.
Good. So again, ask about things that you have at your institution. It's really easy. They either know it, or if they don't know it, they're like, you know what? I think we have one. Let me go grab it. Or just already have it there. Like either one. But again, another way to get people talking. And then if you have people that are new, because I think we've all seen the turnover, right? Yeah, lots of people who maybe haven't been there. So again, talk about, you can just pull those out and it's really simple. Is there a severe hypertension treatment algorithm available?
Yes.
Okay, is it like posted on the wall or where do you guys have it? Like on the wall?
On the walls.
Awesome.
It's in our policies.
Is it in the break room?
Yeah.
They put them just plastered.
So we have a code OB hypertension that we initiate when they meet this criteria for that.
All right.
So that is posted in our break room for sure.
That's great.
Yes.
Okay, is there a triage process for pregnant or postpartum patients outside of labor and delivery?
Yes.
Okay, so what other places have it?
The ER.
Great, okay. How many of you all in your ERs actually have that same kind of policy? How many of you do not? Okay, yeah, it's about half and half. Were antihypertensive medications immediately available?
Yes.
Yeah, it's a SIM. They're right here.
Yeah.
So when you're on your unit and you're running this, one thing we do want you to do is like, if they say like, yep, hypertension, like I'm giving labetalol, like no, go find it.
Yep.
Don't open it, but go get it from the Pyxis. Go get it. Bring it here because that's actually one of the issues. As an aside or just a point, so there's 3 main things we're talking about in debriefing. There's medical care, there's communication, teamwork, and then there's facilities issues. I will tell you from an anxiety standpoint or how confrontational people will get, people say if it's medical things, like they tend to get like, oh, shoot. If it's a facility issue, they just, whatever, that's not their fault. So it's actually a really easy thing to talk about. Like, yeah, I couldn't get the medication out because of the Pyxis. Dadgum Pyxis. Like, you know, like I can blame the Pyxis. Nobody feels bad. Teamwork and communication, I don't know why people don't feel that bad about it. Like, they can be terrible at it, and they just don't feel that bad. But it's something you can bring up and talk about. Okay, escalation plan was in place, including criteria for consultation.
Mm-hmm.
Yep, I thought you guys did a good job. Okay, so for this patient, what were this patient's risk factors for preeclampsia?
She'd had it before.
Yep, she had it before. Absolutely. That is the one, like that is the highest risk. If you had it before, have it again. Awesome. What else?
Her symptoms.
Yeah,
I mean, she
no,
had a
her
headache.
symptoms.
Yeah.
Absolutely. Her symptoms were definitely. And so what was the symptom that made you the most concerned?
The headache that would not go away.
Yeah, headache. Absolutely. Okay, so I'm going to stop. So I'm asking those questions. if there's too much of a pause, I'm going to keep going. Okay, and then I'm going to sound a little bit like I'm teaching, but I'm not putting someone on, like, don't do this. Like, so what were her risk factors? Okay, it's just like, oh gosh. So, and don't just single one person out. Do not look at the most junior person in the room and be like, okay, it will not get you points, and then people will be quiet. Okay, so let's go over response. Okay, so provider team, I'm just going to read through these, and we're going to talk about what we think. Team recognized severe hypertension in a timely manner. I think you guys did great.
Yes.
You saw it. It went off. You're like, yep, that's severe. Everybody else in the room knew it was severe, so that was good. Called for additional assistance. So who's your first person you call for?
Backup nurse, charge
Yeah.
nurse, anybody.
Yeah, absolutely. And I thought that was totally reasonable,
Yep.
and you guys did it quickly. Elicits a patient history of severe symptoms. So I heard you guys talking about symptoms. So what were the symptoms you guys asked about? So
She asked me about headache, abdominal pain, contractions, nausea.
And the headache.
Yeah.
Yeah.
Yeah, no, I agree. Okay, so I'm going to stop. So as I'm going through this checklist, so those first couple, we talked about them, but I kind of kept going. For that third one, in terms of the patient severe symptoms, I already knew all that. Okay, like I knew what she asked, I knew what she said, but I'm still going to ask, because if I ask and I know they did it right, then they're going to keep going, and it just basically like, oh yeah, hey, we did this, we did this, we did this. So again, it's okay to ask things you already know the answer to. I know it sounds devious, but it's not. It's getting people engaged. Okay, did we order labs?
Yes.
Yes, we did. What labs did we order?
CBC, CMP,
Yeah.
protein creatinine ratio.
Absolutely. And I mean, I think the nice thing, first of all, everybody always draws labs. The IV goes in, there's a rainbow, there we go. Like, that's really easy. Did the labs change anything, or would they change anything in this scenario?
No.
Yeah, no, they wouldn't change anything, because severe hypertension with a headache, that's really clear, especially at term. Okay, administered antihypertensive agents for severe range hypertension.
Yes.
Yes, okay, so what are the protocols you guys have at your institution?
So, like I said, on the standing order, we start with 5. Usually our doctors will go to 10
That's hydralazine, right?
with the hydralazine.
Okay, got it.
Yep.
All right,
But
start
with the
with hydralazine.
labetalol, we could start at 20, take a blood pressure 10 minutes later. If it's still severe, you do 40.
Okay.
10 minutes later, still severe, you go to 80.
Okay, no, that's good. Okay, so your standing orders are hydralazine.
Yes.
Okay, no, I think, how many people here say hydralazine? You're at the same place, okay? So hydralazine, all right. Okay, say hydralazine, I think it's great. I think I'd say I use it all the time. I tend to go to labetalol first, but there's no right answer for that. It's, I think one of the things, so I'm going back through the medication, so who is giving the meds? Okay, so you're giving meds. Okay, who is our hospitalist? Got it. Okay, so it was hydralazine, and then it was labetalol. So tell me about your protocols for labetalol. Like, what do you usually do?
For labetalol,
Yeah.
we do
Everybody's.
We do 20, repeat the blood pressure, take the blood pressure in 10 minutes.
Okay.
And then do 40.
Okay.
Is our protocol.
All right.
And then 80, 10 minutes later if it didn't.
Okay. No, I think that makes total sense. So when I was keeping track of stuff, so I heard the hydralazine, which I love. I think that's great. And then I heard the labetalol 20. I think you gave it twice.
I did.
Like, I heard it twice. So, it's not 40. Like, it's still going to say you're still giving labetalol. But, like, what were you thinking when you were talking about 20, like twice?
That was an implanted mistake.
Oh, come on. You're not supposed to do that. This is the hard. Okay, so, yeah.
Oh, what?
So,
Oh, I didn't want to drop her blood pressure to a.
doesn't count now. So here's one of the
Sorry.
things. So here's one of the things we try and do when we're practicing and stuff. Like, we'll try and like implant something that's like a mistake. So we're going to debrief about how to do it, and like, okay, what if they say this? How do you do this? That kind of stuff. So, but the hardest thing is, I try and have people make mistakes, and they're like, but they're going to think I'm stupid. And I'm like,
Oh, I didn't
no,
care. I
I
just
promise
forgot.
I'll tell them. And they're like, it's just really hard. Okay, so let's say, so everybody knows that was the wrong dose, right? 20, 20, 40 instead of 20, 40. Okay, so let's say that the answer was, well, I didn't want to drop their blood pressure. Okay, so
She's about to get an epidural. I didn't want to drop her.
she's going to get an epidural, I didn't want to drop her blood pressure. That sounds like you've heard that before. Okay.
Many times.
So in that case, I'd say, okay, so you didn't want to drop her blood pressure, and you're talking about an epidural. So is that something, it sounds like that's something you've heard before here.
I have. I feel like some anesthesiologists, CRNAs, will have physiologic reasons that they will explain as to why, they do interfere. And sometimes,
Yeah.
we do see that happen, just, not routinely, but it
Yeah.
happens.
Well, they're wrong.
Yeah.
No, I'm kidding. I'm not going to say that. It's.
The brain doesn't care.
I'm not going to debrief that way. Okay. So let's say you get that answer though. Like, hey, they blah, blah, like, okay, well, you know what? That's really interesting. So, like, I can understand the concept behind that in terms of like not wanting to drop blood pressure with an epidural. Like, I can understand the concern for that. I think that probably, especially with the hypertensive protocols we have, like going with that, the brain is probably more important in terms of, with regards to severe hypertension. So I would lean on that side, and maybe that's a discussion that we can sit down and have with the anesthesia later. Because I understand the physiology behind it, but I think maybe this is a case where maybe that's not the approach we want to take. Okay, do you guys see how, so we can take it offline later. Okay, I'm not gonna get in an argument. I'm not gonna make them feel stupid, but we're gonna get back to the protocol. Because one of the things is if there's a mistake in the debriefing that they did, you have to address it. You ethically need to do it, or else everybody's going to walk out of there thinking it's okay. So even if it's uncomfortable, you still have to have that discussion. Okay. I'm going to give you guys a C on that. No, I'm just kidding. You did great. It's everybody like, I didn't want to make a mistake. Okay. Let's see. Did we order magnesium sulfate?
Yes.
Yes. How much?
4 grams.
4 grams, okay,
Loading
good.
dose, and then
Loading
2 grams
dose.
an hour.
Love it. Okay, and so how quickly does that go in? Over what time period?
Well, the 4 grams?
Yeah,
Oh, 20 minutes.
20 minutes. I love it. But what I love is the fact that you say it like that, like everybody knows it, because you're right. Okay. However, there's other places where, if we say bolus, people just open the bag and then we have other
gosh.
issues. So that's good. So 4. Any other doses you see people give?
Sometimes 6 if they're.
Yeah. So again, 4, 6, either
But
one's
I've seen
totally
that
fine.
more with like neuroprotection, like a maybe not with the blood pressure scenario.
Sure. For
Yeah.
either one? Yeah.
Yeah.
So either one's okay. ACOG says either one's okay. For MAG, I always like to emphasize that it's over 20 minutes because I feel like especially people that are newer, when they hear 4-gram bolus, they think bolus, like I'm pushing it in, and that's not something, we've all seen that happen. We don't want to do that. Okay. Did we reassess the blood pressure and retreat severe blood pressure at appropriate intervals?
Yes.
Absolutely. You guys did a great job. You followed the protocol besides the extra dose, and you did great. Did the team communicate about preeclampsia, or the diagnosis and the management plan? Did you guys talk amongst yourselves about what the plans were?
We could have done better.
Kind of? Maybe? Not so much?
No.
Okay. All right. So when you guys were talking about, like, what did you talk about?
That she was going to get induced.
Okay.
So that was her biggest fear, but we did it
Yeah. Okay.
because she was term. So.
All right.
Yeah.
So it's a consult specialist. We already did that. Okay. So let's talk about. I'm gonna flip because she did not seize because the rest of this is seizure.
Right.
Okay. Did they inquire about the patient perspective or any barriers to access in terms of this scenario?
No, we did not.
Yeah. So
We didn't really
what's
get to that.
You forgot to bring up that you didn't have blood pressure cuff, so that's on you. Okay. So the way this the way the scenario is written, I know I'm showing you all the things you shouldn't do. Blame, shame. In the scenario, it actually says like I know I'm supposed to take my blood pressure at home. I don't have a cuff, and then they're supposed to ask why and kind of inquire. So it's okay. We'll get to that. Let's talk about who's the first person? Who's the first person in the room? You, second person. Okay, so when you walked in, what did she say to you?
So she gave me a quick SBAR report and told me about the patient.
Yeah, so what did she tell you about her?
That she was a 36-year-old. This was her second baby. She had preeclampsia with her first pregnancy.
Yeah.
And informed me of her vital signs and symptoms.
Good, okay. Is there anything else you would want to hear at that point, or do you think that was like enough to get started?
I think with as high as her blood pressures were and having too severe at that point, that was a very quick synopsis of the scenario so we could get her treated and all the code activated.
No, I agree. So one of my favorite things to do is like, you're the first person in the room, you're the second person in the room, tell me what you heard when you walked in. Or if there's a lot going on, when the physician or the other people are like, okay, when you walked in the room, what did you hear? And then they'll tell you and say, okay, great. Is there anything else that you would want to hear in that scenario? And the answer often, especially in these simulations, because you don't have that much information, is there's really nothing else. Or, you know what I'd like to know? I would have liked to have known what her baseline is. I would have liked to have known if she'd had labs. I would have liked to have known. So again, and I think in this situation, everything you told her, I thought was great. Like, I think you covered everything. I think it was succinct. I think it was appropriate. So I thought that was really good. Did we call for assistance in a timely manner?
Yeah.
Yeah, you guys did great. Do we use call-outs to communicate important information to the entire team? Here's this, here's that kind of stuff.
I feel like you did when you gave the medication.
Like when I gave the medication,
Yeah.
to say it out loud that I gave
Yeah,
it.
no, I heard some of that. So any evidence, any examples of closed-loop communication? Like you ask for something and then they come back and say, yes, we've done this, here it is?
Yes.
Yeah.
You did.
Yeah, like what?
When she was giving the medications, she said that they were in, and then I wasn't sure if she had started the mag yet, and so I asked her if the mag was infusing, and she said that the mag was going in, so just
Yeah.
closing those.
No, and I think these scenarios are like a really good place to look at closed loop communication, especially because it's medications, and that's a really easy one. Like I've ordered the medication, and then you come back and say, I've given the medication, and you do dose and also route as well. So saying those things, there's a lot of opportunity for that in here. So I thought you guys did well. Maintain situational awareness. Do you feel like everybody understood the seriousness of it and was moving forward?
Yes.
I liked how Stephanie, so Lori says, have you called the code? I'll do that. And then Stephanie said, I need help starting an IV. Like, I need labs and I need an IV. It's just like very clear with what she needed from the second responder.
Yeah,
Yeah.
I agree. I think you guys are doing a great job moving forward. Provide mutual support and task assistance. I think that's exactly what that was. Like that was, people starting an IV, getting this, doing that. I thought that was really good. How well do we explain the situation to the patient using patient-friendly language and tone? How do we do? So this is where you can talk to the person. Like, so what did you hear? Like, how did they talk to you?
So I think probably they told me I had preeclampsia, I was being induced. And since maybe I had it before, they didn't really explain all that was, but I think maybe the patient probably could use, don't assume
lot more.
because they had it before that they know everything about it,
Right. Or that they,
Area of opportunity.
yeah, or that they remember
or that they remember.
what it was
Yeah.
like last time.
No, that's a good point. And the other thing I'll say is that you guys work together.
Yeah.
So,
Yeah.
them talking to you, it's a little bit, like, it's kind of hard. And I think we talked about the patient thing, like, it's a little bit hard because there's a level that we're going to assume in terms of that stuff.
Yeah.
Okay, so I'm going to stop for a sec. So part of that is, so in the communication with the patient, and I actually heard you say it, just couldn't hear on the microphone, like, she's like, area of opportunity. I'm like, yeah. So in terms of like having more of a discussion with the patient, like what would you really say to them? It's also okay to blame the simulation. Okay, like let's say that, okay, like in that situation, I would expect to have more of a conversation like, look, I'm really sorry. I know you don't want to be induced. Here's where we are. You have preeclampsia with severe features. It's really important that we do have a baby now, and there are risks to keeping you pregnant. So let's talk about this. And with the real patient, so you can also say like, look, I know this is a simulation. You know her. I know what you probably would have said. It's okay to say that too, okay? Because then you're going to get to that. I have how many minutes? 15. Okay, that's plenty of time. So anyways, so when you're debriefing, it is okay to blame the simulation. If they say, well, in a real situation, I would do this, be like, you know what, that's fair. Like, this is a fake belly. I'm making noises with the vital signs. That's totally fair. But then you can also turn them around and say, like, in a real situation, have you ever blank? Okay, so again, it's fine to blame the simulation because it lets them off the hook. You can also bring it back to anything that was real. Okay, like, you're like, well, I didn't say, the vital signs, blah, blah, because they were over there. Like, yeah, no, that's totally fair. Have you ever been in a situation where, like, there was so much stuff going on that you didn't see the vital signs? Like, oh, well, yeah. Like, or the blood pressure cuff didn't work or something else. So you can also bring it back to reality if you want to. Okay. Last two questions. Overall team communication, how would you guys rate it? On a scale of 1 to 5, 5 being we're just the most amazing things ever, and 1 being I think they're going to cancel our sitcom.
I'd say a 4.
4? Okay. All right, 4. Why a 4? What so if you're saying 4 and not 5, why 4?
I feel like that we could have explained a lot more to the patient and involved the patient a lot more.
Okay. So the other thing is, because there's scales on here, if you use the scales, people will very rarely rate themselves 5. Some people will because they're awesome and they like themselves. But in general, people will say 4. Sometimes it feels really crazy, they'll say 3. Rarely do they do less than that. So if they say 4, it gives you the opportunity to ask a question like, all right, 4. I agree. I think you guys did really well. But you didn't give yourself a 5. So if you were looking for that 4 to 5 level, like what would you do? And then they've already rated themselves, and then they can provide you that answer. Overall team performance. What do you guys think?
I mean, a 5. She didn't
5? Okay,
cease.
5. All right. So again, well, except that you gave the wrong medication. But
That was the
we already talked
doctor's
about that.
fault.
We already talked about it. That was the
That was the doctor's
fault. Okay. So, all right. So lessons learned, like things that we're going to change. So this is where on your sheet you want to go through and be like, okay, what are the things that we identified here? Was it hard to get medications? Was it hard to find this? Did we call for help in time? Like patient-friendly language and tone, how are we going to explain that? Like this is where you actually write the things down that you've identified on your unit when running it. And then you assign somebody to basically look into that and then what that feedback loop is going to be.
Yep.
Okay. All right. You guys did a good job. Let's give them a round of applause, everybody. Okay, so let's say, we're never ahead of schedule, but every once in a while it happens. So now we're going to figure out our timing, and we're going to assign groups. And then I think 2 of the rooms are downstairs, 2 of the rooms are upstairs. We're going to assign you, we're going to give you a few minutes to get there. And then we're going to go and we're going to practice these simulations. Okay, so you guys are going to get to go. You'll have a great time. Your debriefers will be in there with you, so we're going to let you run simulations, and then we're going to help you debrief them. Okay. I can just give this to you down here. You don't have to come all the way up.
Thanks. I'm gonna use that mic. Thanks. Okay, here's where those dots on your table come in handy that you put on the back of your badge. I'm going to give you some general instructions about what we're going to do for the next couple of hours, and then tell you specifically if you're in Group A. Group A is going to simulation first, and we've got some time to transition. As Shad said, there's 2 of the sim rooms are down here and 2 are upstairs, and I'll tell you more about that in a minute. But we have 5 minutes to transition, maybe a little bit more since we're running a little bit ahead. So at 1:20, you want to be in your sim room, ready to sim, and you'll be there for 75 minutes, and then you'll have a time to a 10-minute passing break, so time to go to the restroom, whatever, to come back here to the ballroom for storyboard rounds. And then for Group B, you'll start in this room with storyboard rounds, and then you'll have a break. For Group A, you'll have a break and then storyboard rounds. And then Group B, you'll have a break, and then transition to sim. So, Group A, you're here. So, Group A1, you'll be making your way to Chenault, which is it's out the right side of the room. And then Group 2, or A2, will be in Del Valley, which is out to this side of the room. And you'll be with Carrie or Jamie and Nika and Maria, and then Shad will float between those rooms. If you are Sim Room 3, you will follow Susan and Rocky and Mindy up to Violet Crown, which is on the entrance level where you came in. And then if you're Group 4,
You'll also make your way up to the entrance level, and you'll follow Brooke, Jenny, and Lauren to Wildflower. So then if you're Group B, we'll go over your assignments after storyboard breakouts. Group B stays in here.